If you guys remember, I talked about the disease chart extra credit. That will be a good way to help you prepare for the final too. The final's not cumulative. It just covers these last chapters, which are 23 through 26. And 25 and 26 are really short. So it seems like more than it is. But essentially, before December or whatever day that is, the 7th or the 8th, we got to get through this here. But a lot of this is worksheet too. So there's not as much as it seems. And I think at the beginning of where the worksheets start, and the pages aren't numbered. I should maybe in the future put a table of contents. So like right where it ends and the worksheets begin, so where there's roughly like this much left, and it says review outlines, I put a thing called useful definitions on there. And so that might be some stuff you want to review so that when you read questions, you know what I'm talking about. Like I'm not going to define contagious again, right? Like we should kind of know what contagious means. Or if I say something's vaccine preventable, you know what it means. Or if I say it has high mortality, you know what that means. And so that was my little list of key terms that I found would be useful for you to study the diseases. So you'll want to familiarize yourself with that. So yeah, the big things you guys have left to do is the lab final. The lab final is online. It's already there, like it's been there. Hopefully you see where it is. I'll remind you about it, of course. It's not due until the end of the first week of December. It's open notes, one attempt, 75 minutes, which is a class period. So hopefully you guys will be able to do well in that. And then you just have the final in here, which is exam 6, and that's this booklet here. So that's it. Any questions? Yes?
Did you already pick up your exam?
Number 4? Yes, I did pick up a few strays. There were a few stray exams. Some people told me they were going to take it and then didn't too, so sometimes I get like they haven't yet and I'm just like, so anyway, I go every couple days and pick up from the testing center. So I haven't gone today, but someone picked them up for me yesterday. So, any other questions? We did it! We did it, you guys! We're almost done. I'm proud of you. I know it sucks right now, man. It's like getting all depressed, like COVID. So I had been avoiding researching COVID because the way my anxiety is set up, I was like, this is not good for me. Like, I'm struggling. And then when I was like looking it up for the class, I was like, oh God, we're all gonna die. Like, even though it's not that bad, but there's a lot of just interesting weirdness about COVID. And then there's a lot that we don't know. And I think that's what makes it so anxiety-inducing, is that we don't really know what's happening. So anyway, we're just doing our best, I guess, to survive and stay healthy. So I hope you guys will stay safe during Thanksgiving and still make good choices and protect yourself. Okay. All right, so chapter 23, cardiovascular system and lymphatic system. So the cardiovascular system, as many of you already know, is how you move blood around with the heart, which is a pump, and you're moving it to the lungs to get oxygen, and then pumping it to the rest of the body, delivering it to the tissues so that you can have oxygen for metabolism. And then kind of adjacent to the cardiovascular system is the lymphatic system. So a lot of times in textbooks you'll see the lymphatic system with green vessels. It's not run by a pump, but it's your drainage system, essentially. So the interstitial fluid, which is the fluid that bathes your cells, it can collect things that leak out of the blood vessels, and then they can enter into the lymphatic vessels, and if there's anything in there that's foreign or potentially harmful, like antigen, then you can also mount an immune response. So that's the other important function of the lymphatic system, is the immune response, as well as drainage. So these are areas of your body that are normally supposed to be sterile. And so there are some pathogens, though, that can cause infections in these systems. All right, so one of the things we talked about that's probably a little bit more complicated, and again, I'm not a clinician, so I don't always know the subtleties of different like care plans and things like that. I just kind of know in general what happens during sepsis and septic shock. So it's kind of a continuum. Often it starts as bacteremia, which is where you have bacteria in the bloodstream. Sometimes you can see evidence of an infection spreading along the lymphatic system, and that's called lymphangitis. So if you see red streaks coming from a wound, it's kind of an ominous sign that it could be attempting to spread. As we talked about before, with inflammation, it is better if it stays localized. Because of the chemicals that get released, they cause a lot of unwanted kind of side effects, especially with hemodynamics, getting leaky blood vessels, which that can lead to the shock, which is where the blood pressure drops so low that it can't sustain life anymore. And so usually people expire from cardiorespiratory failure when they have sepsis and septic shock. So it's not an illness, but it's a syndrome. It's a collection of signs and symptoms, and they're not totally sure exactly what triggers it, like maybe why some people get severe sepsis and some don't, but it's in a patient that has a suspected infection. So the other weird part about it is that they don't always know what caused the infection. Like sometimes they have an idea, but sometimes they actually never find out. So this is where you have the life-threatening organ dysfunction. A lot of times, like the kidneys will fail. If the kidneys fail, that causes fluid overload, which puts pressure on the lungs. And then if the lungs aren't working great, then you're not going to get oxygen to the heart. And then if the heart's not working very well, then the brain kind of goes. So those major organ systems fail. And it's a very complex cascade that I'm sure some of you who are going to go to nursing school will hear much more about it in detail. So septic shock is a smaller group of people who develop sepsis that actually get such cellular and metabolic abnormality that they have a profound and increased risk for mortality. And again, the hallmark sign of kind of having septic shock is life-threatening hypertension, so blood pressure getting super low, even in the presence of using vasopressors, like the blood pressure just cannot be maintained. So the signs of sepsis and septic shock are that you have increased lactate. Lactate is a marker for damage, like cell and tissue damage. Increased respiration rate, again due to the struggle that the lungs are having with all the fluid buildup. Increased need for the vasopressors to maintain blood pressure, so you're having trouble maintaining your own normal pressure. And then altered mental status. So sometimes people will be confused, or they'll be all the way to the point where they're basically in a coma, like they become unconscious because of this. So risk factors for sepsis is anyone who could have possibly acquired an infection, such as pneumonia. If you had recent surgery, birth, abortion, or some kind of physical trauma, if you have a long-term indwelling device, and that's part of the reason why they try to keep those devices, they try to keep you on them the shortest time as possible to prevent you from getting these catastrophic infections. Age is a big factor. You're more likely to get sepsis if you're elderly. Being immunocompromised, you're more likely to get sepsis. And any microbe could cause sepsis, but bacterial sepsis is the most common. And actually the term sepsis means contamination. So it's a bacterial contamination that's causing a system-wide inflammation instead of a localized. So sepsis is a common cause of death in people that are hospitalized in the ICU. And it's also a fairly common cause of newborn deaths. So severe infections, which include sepsis, make up about a quarter of newborn deaths. And so that is something to be aware of. Like they say that, it is not normal. It's an emergency if a baby under the age of 2 months has a fever, because it's a sign that they could have a severe infection that they maybe acquired during childbirth. Okay. All right, so I said bacterial sepsis is the most common. And then it's divided into gram-negative and gram-positive. Gram-positive is the most common cause of all sepsis, and that's because you're covered in gram-positives. Remember we said that normal flora that lives in your body inside and out is gram-positive, so the most common causes are strep, staph, and enterococcus. And then sometimes you can have gram-negative sepsis. If you have a really bad UTI or kidney infection, you can get urosepsis from that, especially if you're elderly, where it can spread from the urinary tract to throughout your body. If you have some kind of abdominal issue, where you have any bacteria from the intestines leaking into the peritoneum or in the abdominal cavity, that can lead to gram-negative sepsis. And so the most common causes of that are E. coli, Klebsiella, and Pseudomonas. And it's due to that endotoxin that they have in their cell wall. As your immune system attempts to fight the gram-negatives, it actually releases the endotoxin, and then that contributes to this systemic inflammatory response. With gram-positives, a lot of it is when they produce toxins like superantigen. If you remember, we talked about superantigen. It overstimulates the immune system. So it causes a non-specific, amplified, abnormal reaction. All right, so how do you diagnose sepsis? As I said, you look at the vital signs, respiration and pulse rate and things like that. Lab values, and there has been a new test recently approved by the FDA that looks for a biomarker that's called procalcitonin. They've noticed that PCT is a better, more reliable marker of sepsis than lactate is, because lactate is a little more generic, I guess. So now they've started using procalcitonin, and there's also a cool new machine, and I put links to it if you're interested. There's a cool machine that allows you to rapidly identify fungal sepsis, which is becoming a more emerging threat. A lot of the times, if you suspect a patient has and they're just sepsis and they're not responding to antibiotics, it could be because it's due to like yeast, like Candida, and so that's another thing to consider in your differential diagnosis. So you evaluate the signs and symptoms, including general lab work and vital signs, and then you look for evidence of previous or current infection. So you do blood cultures, urine culture, lumbar puncture if you think they have meningitis, sputum culture if you think they have pneumonia. You can see signs of distress, respiratory distress, by doing the pulse oximetry, which is really easy to do, the little finger thing that measures your oxygen levels. CT scan, MRI, X-rays, those are all ways that you can see if there's any inflammation, if there's anything in the lungs, if they look clear, that kind of thing. So you're looking for evidence that there is infection, because that is what would make you think someone has sepsis, is that there's a suspected source of infection. All right, so they recently changed the categories for defining sepsis. It's kind of confusing. I came across it actually accidentally. Since I'm not like a clinician, I didn't know like what criteria they use. And they used to basically divide sepsis in the olden days, which were just a couple years ago, as sepsis, severe sepsis, and septic shock. So they took out that middle category because there's kind of like, it's like a gray area. Like you pretty much just like, it's severe, like once it gets kind of to a certain point, like it's just kind of all the same, I guess. So they used to call it something called systemic inflammatory response syndrome, which is why they used to call it SIRS. But now with the new criteria, in order for them to say that you have sepsis, you have to have a suspected infection. So you look for the evidence of the infection. And then this QSOFA score that's either greater than 2 or has a rise that's greater than 2. And so that is on the green chart that I found. So this is the quick sepsis-related organ assessment. And so the 3 criteria that they use to evaluate if they think you have sepsis is first if they suspect an infection, and then on top of that, increased respiration rate, altered mental status, so they do this Glasgow Coma scale. I looked it up, but I don't remember like the criteria for it. It's probably like a checklist, like how are they responding to stimulus? Can they talk back to you? Can they answer questions? Things like that. And then low blood pressure, so systolic blood pressure is less than 100. And so the higher that score gets, the more likely you are to have sepsis, and also more likely maybe to progress to septic shock. So then the criteria for septic shock is that you have sepsis, which means you have these things going on that are in the green category, and you have hypertension in the presence of vasopressors. So they're starting to max out the vasopressors and it's not working. And then lactate greater than 2. So they kind of simplified it basically to say that you either have sepsis or septic shock. So sepsis can be, I guess, severe technically, depending on how deranged your numbers are. But shock is kind of like the end stage, and it's the phase that would be the most dangerous, like the higher mortality. So as I mentioned, that procalcitonin test, before they developed that biomarker, they used to use more non-specific things, like CRP, which is C-reactive protein. But CRP is a very generic marker for inflammation. So it could be elevated for any reason. It could be elevated in certain cancers, autoimmune disease. It could be elevated if you have cardiovascular disease. And so they were looking for something that was more specific. The other thing they noticed is that CRP takes longer to go up when you have sepsis. And ideally you'd want to diagnose sepsis as fast as possible. And so they noticed that the procalcitonin and the PCT elevates more quickly to detectable levels. So by the time you're say 6 hours into this situation, you will have a noticeable rise in PCT. And so that's what makes it a little bit more accurate. Something out there that I should know about?
It's a man laying out there with his dog. I thought it was a deer.
Oh, okay, cool. So as long as it's not anyone trying to murder us. Then I want you to be like, murder's happening. Okay, that's cool. Well, that sounds chill. That's nice. He's hanging out with his dog. All right. So procalcitonin, a better marker for early sepsis. And then they've even been able to kind of make a little algorithm where as it goes up, depending on how high it goes up, you can use that to figure out what stage they're kind of in. So a healthy person would have a very low amount, 0.05. If they have a localized infection, it goes up like tenfold, so it'll be 0.5. If they have a systemic infection, so they have sepsis, you'll see it be at least 2. If they have severe sepsis, which they kind of have taken away that designation, then it jumps up to 10. And then anything but over 10, they would consider that to be septic shock. So it's a way that you can monitor basically where the patient is as far as the disease process. So this is another algorithm that's talking about what do you do with the antibiotics. So basically, if the PCT value is low, then you can stop using the antibiotics if they're clinically stable. If the PCT value is above 0.5, then they recommend that you don't stop using the antibiotics. And so again, it correlates with treatment. The lower the procalcitonin drops, the more you might be able to stop using antibiotics because it means the infection is kind of under control. Okay, so the signs and symptoms of sepsis, shivering or cold. Sometimes people don't have a fever, they actually are running cool. Again, probably due to all the hemodynamics being off and blood flow being off. Extreme pain and discomfort, clammy or sweaty skin, confusion or disorientation, shortness of breath, and having a high heart rate. Those are kind of the classic signs and symptoms of sepsis. So treatment, oftentimes they have to just blast you with antibiotics because they usually have a general idea of what it probably is, like what's most common. But then if they get cultures back, they might have to adjust it. And then if it's not working at all, then they might have to investigate, is it fungus or some other less common cause of sepsis. Organ system support. So usually a lot of times they're going to need intubation, be on a ventilator. They're going to need to get a central line to get that fluid up. Antihypertensive medication. Those are the vasopressors, which raise the blood pressure. And dialysis, because those delicate kidneys just get really messed up during sepsis. And sometimes that can be irreversible, like they might end up being on dialysis, especially if they're an older patient. And then surgery, so if they have signs of a very obvious aggressive infection, then they can do debridement or worst case scenario amputation to remove that damaged infected tissue so that the infection will stop spreading. So basically, most at risk for death, it's age related. So if you're a newborn or if you're elderly. As I mentioned before, the ultimate cause of death is usually cardiorespiratory failure. And luckily, as far as how common, sepsis is the most common, followed by severe sepsis, which they kind of removed that and kind of lumped this all together. And so getting septic shock is just the tip of the iceberg. So, oh my God, that's a bird?
Yeah.
Is that a bird?
Yeah.
Dude, so once, I don't know like what this means, but one time I was at my therapist's office and she had this big window and this bird just like, bam, like died right in front of us, and I was like, I'm sad now. I'm here with you. Like, anyway. What's going on out there? Okay. So what this diagram is showing is that septic shock is not that common, but it has the higher mortality rate. Okay, so again, it kind of represents the worst case scenario if a person gets sepsis, is that they could actually go into septic shock. Have you guys seen that Alfred Hitchcock movie, The Birds? Classic. You haven't? You should watch it. It's ridiculous. Anyway, all right. So that was sepsis. Okay, sepsis is due to suspected infection resulting in system-wide inflammation that leads to multi-system organ failure. Okay, that's basically what happens with sepsis. Now, the next thing we're going to talk about is infective endocarditis, which is rare in healthy people. And any part of the muscle wall could be affected. So if it's the heart muscle itself, that's called myocarditis. If it's the inner layer, that's called endocarditis. And if it's the sac around the heart, it's called pericarditis. General signs and symptoms, 80 to 90% of the time you're going to have a fever. So it's going to be kind of a flu-like illness. But then you're also going to have an abnormal EKG, and sweats and chills, weight loss, poor appetite. So a flu, and then plus these cardiovascular issues. So one of the things that can happen that has it's a little more dangerous, is if you have pericarditis, you can get what's called pericardial effusion, which is where a bunch of fluid fills around the heart, and then that can lead to something called cardiac tamponade, which is where that fluid actually compresses the heart, like compresses the chambers of the heart. And so that's going to reduce your ejection fraction. And so I guess infective endocarditis can like rapidly cause heart failure. Like it's a cause of acute heart failure basically. So bacterial infection is the most common. Normally your immune system will prevent bacteria from entering into your heart. So it's rare in healthy people. But some of the risk factors are if you have previously damaged heart valves, they're more likely to get colonized with bacteria because they're structurally abnormal. Same thing if you are born with a heart valve defect, like mitral valve prolapse, you're more likely to get bacteria deposited and sticking to those valves. They used to recommend prophylactic antibiotics, like if you were getting a dental cleaning, if you had a heart valve problem, but they actually don't recommend it anymore because it doesn't really help. Weirdly, when you get your teeth cleaned, you actually release a lot of bacteria into your body, but a healthy person, that's not going to do anything. And it's mostly bacteria that aren't harmful, but in the right person, that bacteria could cause infection somewhere else in the body. So the usual risk factors, immunocompromised, age, having already faulty heart valves, and then really a huge risk factor is IV drug users because they're directly injecting bacteria potentially into their bloodstream. So what ends up happening is this gross like scarring in the heart, which is what they're showing here. This is all scar tissue. They opened up the heart and you can see the scar tissue, and they call those vegetations. It's where that bacteria has landed in the heart and caused inflammation, and your body is attempting to wall off that damage. But as you can imagine, replacing healthy heart tissue with scar tissue means that the heart is not going to function the way that it normally should. So any organism technically can cause endocarditis, but the most common are bacterial, and again we have our gram-positives. So we got Staph aureus, which lives on your skin and in your nose, and then we have strep. We have strep mutans, which comes from your mouth. Viridans strep, which is this normal strep, I guess, that lives on your body. and then group A strep, which likes to colonize your throat, and those can have been linked with infective endocarditis. Neisseria, rare, that's a gram-negative cause, and so I think if people get like an uncontrolled meningococcal infection, then they can get endocarditis from it. And then chronic disease comes from tuberculosis. So tuberculosis can actually infect other organs besides the lungs. It can infect the heart and the liver as well as the lungs. Okay, rheumatic fever is an autoimmune complication due to having group A strep. It causes joint pain and then these nodules to form, which are due to kind of an overactive immune response. So the immune system is trying to respond to the strep antigens, but it ends up manifesting in autoimmunity. And so this is something that is actually pretty rare these days. It used to happen more frequently when we didn't have antibiotics for strep. Now that we can treat strep effectively, it's really rare for people to get rheumatic fever, but it's still a cause of heart valve damage if you have that infection and it causes like the scarring. So how does the heart get affected? So having that inflammation leads to necrosis of the heart muscle. And depending on how much of the tissue died, the spreading of that dead tissue is called infarction. And this can lead to, as I said, a rapid heart failure. So infective endocarditis would be a cause of rapid heart failure. A cause of like chronic heart failure would be something like hypertension, having that for a long time. Okay, so how do you diagnose it? It's pretty simple, the usual heart tests that you would do. So EKG, MRI, X-ray, echocardiogram, which up on the right is actually showing like a cross-section of the right atrium, the left atrium, the left ventricle. And notice that you can't see the right ventricle. And that's due to the pericardial effusion. So there's an infection that's causing fluid to build up in the pericardium, and it's compressing the heart muscle. I mentioned those gross vegetations that you can see. This was an HIV positive young man who was an IV drug user, and he was only 24 years old. And this is what his tricuspid valve looked like, all those gross valves, and this was post-mortem. He passed away from this due to the IV drug use and it not being sterile. So like I know it's controversial when they talk about like needle exchange programs, but I'm like totally for it just because I'm like if people are gonna do the drugs anyway, like why can't we help them? Like why do we demonize people that have addiction? Like it doesn't make sense to me. So anyway, poor guy had very infected heart valve. And it was due to Staph aureus, which was probably just on his skin, and then with his lifestyle, he injected it underneath. And then this is showing an X-ray of pericardial effusion. So this is the heart, and then all this like open space around it is where there's excess fluid, and so you can see that with regular X-ray too. Okay, so that was heart diseases. That's all I have for that. And now we're moving on to the lymphatic system. And a lot of this is review because we've talked about malaria before. So malaria is a blood parasite. The organism is called Plasmodium falciparum. It's a protozoan parasite, a blood parasite. It's spread by the mosquito that's called Anopheles. It can have a very long incubation period, so that's why a lot of times if someone travels somewhere where malaria is common, they might not know that they got it until they get back. So it can hang out in those blood cells for a while. You can diagnose it through a blood smear, and you can see the little parasites inside of the red blood cells. If you're a parasitologist, they'll look very, obvious to you. So malaria is very common, especially in the tropics, because that's where the parasite is, and that's where the mosquito population is higher. So malaria presents as a flu-like illness. It can be very severe in little guys. So this poor little sweetie here, this 5-year-old, had cerebral malaria. So poor little baby was basically in a coma because of that. That's a severe complication. It doesn't always necessarily go to your brain. but it can. It's a blood parasite, so it can technically end up anywhere, although it mainly likes to multiply like in the liver and in the lymphatic system. And so you have a flu-like illness. Most of the deaths are in kids that are under 5. Pregnant women are at risk, and then non-immune travelers. So you haven't been exposed to malaria before, so you can get it quite severely that first time. We've talked about the life cycle before. Remember, it takes on different phases of the life cycle. So when you get bitten by a mosquito, you get injected with sporozoites. It goes to the liver, and it does schizogony. And then they break out of the liver and have a second form, which is called a merozoite. The merozoites are then what contributes to the red blood cell cycle. And the red blood cell cycle is where you have most of your signs and symptoms. The main pathology of malaria is that it destroys the red blood cells. And then that causes you all kinds of other issues. Remember we said that some parasites know when it's nighttime? So the malaria parasite does this thing that's called nocturnal periodicity. When you are sleeping, your body temperature drops a little bit, and then that lets the parasite know, like, hey, it's nighttime. I should move to the peripheral blood so that I'm more likely to be picked up by the next mosquito. And so what gets picked up by the mosquito are the gametocytes, which are the male and female parts. So there are drugs that interfere with, like, sporozoites and merozoites and gametocytes. There hasn't really been a lot of good treatment of the mosquito. It's more like get rid of the mosquito, like mosquito control. So this thing looks very ominous because it's like death. You don't necessarily die from malaria. It has a fairly low mortality rate. It's kind of a slow-going illness, so you don't have a lot of acute death unless, like, that poor little dude who had the cerebral malaria, then that's going to be more serious. But really, what it boils down to is the red blood cells. Okay, all kinds of bad things happen to the red blood cells that leads to this, like, I almost think of it as like an ischemic assault. Like, because since the red blood cells are getting destroyed, you're not getting oxygen to the tissues. And that causes all kinds of cell death and injury that eventually, if enough of those cells are affected, could lead to the death of the person. Okay. So, as I said, their ability to bind to erythrocytes and destroy them is one of the ways that they are able to cause such problems. They also can suppress your immune system. So this parasite can prevent your immune system from developing properly. And this is showing, I found this really fascinating. This is a microscopic image of a red blood cell and the malaria parasite attaching to it. Like, look how tight it is. They're just going to go bloop inside. So then they multiply like crazy, and they just keep destroying those red blood cells. So obviously people are going to have anemia, but then worse than that, they're going to have ischemia and hypoxic cell injury, which is going to lead to all kinds of organ dysfunction. Okay, so the gold standard for diagnosis of malaria is to do a blood smear, but sometimes you don't have a lab available if you're in a remote area. So they do have a rapid antigen test. They have a test that will tell you if it is malaria by doing a little blood stick, like a little finger stick, like you would for blood sugar. So as far as treatment, there are a bunch of anti-malarial drugs that work. Some of them are for treatment. Some of them are for prophylaxis, which are like the ones you would take if you were traveling somewhere to prevent you from getting malaria. This is just showing that malaria drugs attack different parts of the life cycle, which is something I've kind of said before. You guys don't have to know what any of these drugs do or anything, but I'm just pointing out to you that, like, again, some of them attack them when they're in the blood. Some of them deal with them when they're in the red blood cells. Some of them will deal with them if they're actually in the liver, which is this cycle here. And so that's all I'm trying to point out to you is that oftentimes for malaria treatment, you're going to need more than one drug to attack different components of that parasite life cycle. So prevention, I took this picture, I was like, look at that baby, look at that little chubby baby. So cute. So mosquito nets, right, is a big thing. Bed nets at night. Prophylactic treatment for travelers. The mosquito population control, preventing mosquito bites whenever you can. They make clothes that's treated with mosquito repellent. It's kind of a double-edged sword, though, because the products that contain, like DEET, they're actually safe for most people to wear. And I remember when I was pregnant during the Zika thing, and I wore insect repellent. I was like, I'm not getting a bite, like, at all. But there are impacts on the environment when you use some of those pesticides. And I don't know if I told you guys this before, but like back in 2016, I remember hearing a story where they were supposedly spraying the mosquitoes because they were worried about Zika virus. It was somewhere like in South Carolina or somewhere like in that area. And they ended up killing a bunch of freaking bees instead, which is like, no, like, because bees are like amazing and mosquitoes suck. And so it was just like really sad. So that's the hard thing, I think, is that we got to control a whole nother animal, right? Mosquitoes are just out there doing their dirty work, doing their business. And you're trying to control what humans are doing and also what the mosquito is doing without destroying, like napalming the environment. And so it is a very challenging problem when you're trying to deal with these vector-borne diseases like malaria. And that's probably why malaria is, I don't think it's ever going to go away, like, because mosquitoes are pretty hardy. So control the mosquito population. They've tried all kinds of things. Predatory fish that eat the larvae, worms that will eat the larvae. Some of them are becoming resistant to insecticides, though, so they're having to think of more creative ways to get rid of the mosquitoes. Human behavior and environmental modification. So not storing your water in open containers. Like, my husband always has, like, weird things in the yard, and there was this huge wheelbarrow of, like, water. And even though it's not mosquito season, I was just like, I just dumped it out because I didn't want to give them any chance. Like, it's weird right now, like, with it getting warm and cold and warm and cold. Like, I had a random iris bloom in my yard, and I was just like, what was going on? So I expected a mosquito to come by and be like, I'm back. Anyway, so modifying human behavior, a lot of it has to do with proper water storage. And unfortunately, a lot of the places that are affected by malaria don't have access to clean water consistently. And so they're just trying their best to survive. They're trying to collect the water so they have something to drink and bathe with. But if you leave it in an open system, then that means that insects can lay their eggs in that water, like mosquitoes. All right, this one, sometimes I'm like, should I even mention this? This is like so obscure, but I just find it interesting. So this is lymphatic filariasis, which is actually caused by a worm. So the worm is called Wucheria bancrofti. That's the main worm. This is a neglected tropical disease. It's spread by a mosquito, but a different mosquito than malaria. So malaria was spread by Anopheles. This one is spread by Culex and Aedes. So it's primarily in the tropics, and basically what it does is it reproduces in the lymphatic system and causes blockages that lead to severe lymphedema. So that's what happens when you have this disease. So it's another nighttime biting mosquito. And if you are bitten by the mosquito, it deposits the larvae of the worm into your system. They migrate to the lymphatic system, and they form these basically little love nests where they mate. And then they produce this second kind of version that's like a little thin thread that are called microfilariae. And then those are what get picked up by another mosquito, and that's how the process continues. So this is a parasite that, like malaria, also does the nocturnal periodicity. So it's where they're able to enter into the peripheral blood at night, and that's signaled by body temperature changes of the host. So what it causes is two main conditions: lymphedema, which is like a chronic obstruction of the lymphatic system that leads to pooling of fluid, especially in the lower extremities, but apparently this can happen anywhere: the breasts, the scrotum, the arms, where you get this incredible swelling. And then that continued swelling causes the skin to kind of dry and toughen over time, and that's called elephantiasis. So that's the part where the skin kind of looks like elephant skin. It gets all dry and messed up from the constant swelling. So you can do a blood smear to look for the worm. They do have antibody tests, and they also have antigen tests, but weirdly, people that have lymphedema will often have negative lab tests because the infection was years earlier and they're still having that chronic swelling happening. So there are anti-helminthic drugs. A lot of the anti-worm drugs will destroy the offspring or paralyze them or stop their metabolism somehow. You can use surgery to treat the wounds because when that skin stretches out, it can cause ulcers to form. So really it's trying to do things that are supportive of getting that fluid flowing, so hygiene, compression, gentle massage, exercise, to try to control some of that lymphedema. Because for some people it becomes a lifelong chronic thing that they deal with because the worm infection damaged those lymphatic vessels, and so they're not able to keep fluid flowing the way they should. So not only is this painful, but it's also socially stigmatizing because people feel self-conscious and they can't really interact with their community. And then it's going to cause a lot of disability. It's going to be hard for people to work when they have this kind of issue. All right. The last lymphatic system pathogen is, of course, probably the most notorious one, which is HIV. We've talked a little bit about HIV before, so now we're going to go in a little bit more detail. So HIV stands for Human Immunodeficiency Virus. So as you can imagine, it's a virus that makes your immune system deficient. Okay, so it does that by destroying T helper cells. And if enough of those T helper cells get destroyed, it can lead to AIDS, which is acquired immunodeficiency syndrome. Not everyone with HIV has AIDS. AIDS is kind of like the end stage if your T helper count gets like to a certain point. So the origins of HIV are very convoluted, like they're still kind of filling in that story. But they believe that essentially it jumped into humans probably from some small primates. So the one that is most common these days throughout the world is HIV-1, and that likely came from chimp origin. And then HIV-2 is only in certain parts of West Africa, and it came from this other little monkey that's called a mangy. There's also FIV. Any of you cat lovers may have heard of feline immunodeficiency virus, but I guess in cats it doesn't affect them as much. Like they don't get as sick as humans and other primates do from getting these infections. All right, so how do you get HIV? It has multiple routes of transmission, and just remember that they're all direct. So there's no casual contact that's ever been shown to transmit HIV. It's either sexual, vertical, or bloodborne, like IV drug use or transfusion. There's no cure or vaccine, but we have really awesome antivirals. The little map over here is actually just showing that there's a bunch of different subtypes of HIV. So there's quite a bit of genetic diversity. And that's sort of a problem for us because HIV mutates rapidly, and that's probably why it's been hard to get a vaccine, is because the virus is always changing a little bit. And so it's really good at evading the immune system. So there's a bunch of different subtypes of HIV-1, and it just depends on where you live in the world, which subtype is most common. All right, so overall, in the past couple decades, we've seen a decrease in new HIV infections, but there have been some parts of the world that have alarming increases. And one of those is in Eastern Europe, like Russia. Once this, all those little independent Soviet states became separate, from each other, there was just a lot of, economic and social downfall. And a lot of people were depressed and turning to IV drug use. So IV drug use is a huge problem in Russia and Eastern Europe, and that's what's primarily driving up their cases of HIV. In Africa and sub-Saharan Africa, where it used to just be hyper-endemic, just everywhere, a lot of it has been thanks to public health pushes, getting more people tested so that they can get treated, and then also a lot of focus on maternal health, getting mamas that are HIV positive the proper treatment they need so they don't pass it to their babies. So that has been a really successful campaign in a lot of different countries in Africa. So overall, we see a decrease in new HIV, but there are subsets of population that we're actually seeing an increase. You know that there's like sex trafficking and human trafficking, which is going to not be good for sexually transmitted infections, and then the increased IV drug use in certain areas. So what this diagram is really showing is that today more people are getting treatment than ever for HIV. So back in 2000, only like a fraction of people with HIV were getting treatment. So the orange people are the amount of people that are living with HIV, and then the turquoise color is the amount of people that are getting treatment. And so notice that in the past 20 years, we have seen a great increase in the amount of HIV-infected people that are actually getting treatment, upwards of 50% plus, and that is really what is necessary to stop this pandemic, because a lot of, well, I guess now they're calling it an epidemic/pandemic. It's kind of ongoing. A lot of preventing HIV transmission, besides behavioral modification, is getting the viral load to zero. Because if you get that viral load down, you virtually can't pass it to someone else. And so that's one of the ways that we could potentially deal with and lower cases and eradicate HIV. All right, I always ask about the testing of HIV. So this is a little paper, and this is not big enough for you. I stole it from the CDC if you wanted to look for it. So basically, the new recommendations are to use what's called a 4th generation HIV test. And this is one of those immunoassays, like an enzyme immunoassay, where it's going to use antibody technology to detect antigens. So one of the things that they've realized is that it's actually more accurate to look for the HIV antigen than it is to look for the antibody right away. And that's because you don't make antibodies right away. So some people don't make HIV antibodies for like 3 months. And so the virus, though, is immediately present. And so looking for the antigens is more accurate if you're looking for early infection. So the antigen is something called P24, and it appears sooner than antibodies. So if your initial 4th gen test is positive, then they assume that you have HIV, like presumptive, right? And then they're going to do a differentiation where they're going to distinguish between HIV-1 and HIV-2, because those have different ramifications for treatment. The other interesting thing is that HIV-2 is actually less virulent. It takes much longer for HIV to cause symptoms. It takes longer for it to destroy the immune system. So it's kind of an interesting one, but unfortunately the more virulent one is more common, which is HIV-1. So let's say that your first test was positive and your second test is negative. So now they're like, did they have a false positive? Like, what's going on here? So then they'll do the more expensive test that's more definitive, which is the nucleic acid test. This is going to look for viral RNA. So this is how you get, you detect if they have an acute HIV infection, because if they do, the viral load will be high, so that RNA test will be positive, or to see if you got a false positive with the first test. So if the nucleic acid test is negative, then we assume the first test was a false positive, and we arrive to the conclusion that you're HIV negative. If your nucleic acid test is positive, then they can assume that you have acute HIV infection. So you have just recently been infected, and it's detecting that RNA. Now, if your HIV differential test is positive, then you interpret the person as being positive with HIV-1 or 2, okay, depending on what the results of that test said. Okay? All right, any questions on that? So the tests have gotten really good. Notice that if the 4th gen test says you're negative, right? Like it doesn't have false negatives typically. And that's because it's looking for antigen instead of antibody. So it's more accurate that way. All right. So how does HIV get in and start bugging your CD4 T helper cells? So on the HIV virus, it has an envelope, and then it has these glycoprotein spikes on it, and those bind with a receptor that is on the host cell, and it allows the virus to enter through fusion, so that once it comes inside, that capsid is going to release, and it has enzymes that allow it to integrate the RNA into the host DNA. So we've talked about this before. HIV has an enzyme that's called reverse transcriptase, and reverse transcriptase reverse transcribes RNA into DNA. So that's how it inserts itself into your DNA, which is really kind of creepy if you think about it. So now your cells have a little piece of HIV in them called provirus, and then the cell is going to go through normal metabolic processes of copying the DNA, and what it's doing is actually making new copies of the HIV virus. So reverse transcriptase is a really important virulence factor for HIV, and it's one of our main targets of HIV treatment is to use a reverse transcriptase inhibitor so that it's not able to integrate into the host. It's not able to replicate. All right, so the receptor that HIV typically binds to on the host cell is called CCR5. So there are drugs that are CCR5 antagonists, so they actually block CCR5. If you block CCR5, HIV cannot fuse. So those are called fusion inhibitors. That's a newer class of medication. Now, some people have gotten the luckiest mutation in the world where they have a mutated version of CCR5. And what do you think that would mean as far as them being able to be infected with HIV? They can't be, or it's harder for them to be. So they've identified subsets of populations in the world where these people can't get HIV. They have a mutated version of CCR5. So I don't know if we really were able to get gene therapy to be a thing, if we could alter people's genes to make the mutated version of CCR5, then maybe that would be a way to prevent HIV infection. All right, so they don't know for sure how HIV kills so many of the CD4 T helper cells, but what they sort of suspect is that it's due to apoptosis, which is programmed cell death. So said another way, the HIV induces these T cells to kill themselves. The reason that this happens is because when HIV enters into a cell, sometimes weird little bits of genetic material are left behind. And when your system sees that, they're like, ew, something's wrong with that cell. It's got strange DNA in it. So we're going to induce it to kill itself. We're going to have it undergo programmed cell death. That triggers inflammation. So more nosy immune cells come over. The virus escapes and infects those immune cells that come over. More of those die, and then that triggers more inflammation, and then more immune cells come over. And so you can see that this vicious cycle repeats itself for many years in the lymphatic system until your CD4 count becomes so low that you're not able to effectively fight infections anymore. Okay, so that's one of the ways they think HIV is doing this. All right, so if you have acute retroviral syndrome, and again, the reason they call it a retrovirus is because it reverse transcribes RNA into DNA. It's a flu-like illness. You might not even know if you didn't realize that you had an at-risk event. Then you might just think you have the flu. Okay, you got some swollen lymph nodes, you got a fever, headache, muscle pain, whatever. But as your immune system breaks down, your symptoms will be more systemic and they'll be more severe. And they'll be similar to having severe infections, like the night sweats, the weight loss, yeast infections, nail changes, and even like motor and cognitive decline and neuropathies can happen from chronic HIV infection. So as I mentioned before, the reason that they don't do the antibody test first is because it can take you 2 to 3 weeks, but all the way up to 3 months, and I've even heard some people as long as 6 months, but that's rare, to make HIV antibodies that could be detectable. So that period where it's not detectable yet is called the window period for a diagnostic test. All right, so there's all kinds of funky opportunistic infections that can occur. Different yeast, bacteria, viruses can reactivate that were latent in your body. And without treatment, the average incubation time between HIV and AIDS is like 8 to 9 years. Okay, so you can reach the end stage without treatment within that time. But for some people, it's much shorter than that. It can be like 3 to 5 years. All right, so HAART is HIV treatment. It stands for highly active antiretroviral therapy. And these are some of the drug targets that I was talking about. So fusion inhibitors prevent the HIV from fusing with the host membrane. There's a bunch of different reverse transcriptase inhibitors because that enzyme is critical for HIV replicating. So a lot of drugs target reverse transcriptase in different ways. Protease inhibitors interfere with protease, so they are not able to uncoat properly. So then they're not going to be able to take over your cell. CCR5 antagonists are the ones that I was saying block CCR5, so that HIV is not able to fuse inside of the host cell. And then integrase inhibitors. Remember I said that HIV inserts its little gross DNA into your DNA? Integrase inhibitors block the enzyme that does that. And so it's another way to stop replication early on. They're not able to put it into your DNA. So I find these medications like super fascinating. If you understand how they work, then you understand the life cycle of HIV inside of the cell because they act at different parts of that cycle. All right, so since we've had HAART introduced in the mid to late 90s, HIV rates, death rates have gone down for pretty much everyone. But notice that there's still some populations, especially black males, that remain higher than other populations. And it's kind of beyond the scope of the class, and I can't even begin to postulate why that is, but I mean, there's just going to be cultural differences, there's going to be socioeconomic differences, there's going to be differences in access to quality health care. And so there's a lot of reasons why healthcare disparities exist. And I think that that's something that you guys should, try to remember when you're clinicians is that not everyone has the same opportunity. Like I know we like to think that that's true, but it's just not, okay? All right, so I came across this data and I was like, dang man, this is like stark. So this was from Florida where in the early phase of HIV and AIDS, they were looking at the time from diagnosis to death. And look how short it was. I mean, it was a terminal illness immediately. And if you were black, I mean, literally it's a death sentence, like, you're going to die, like, pretty much within that time. They didn't have a treatment yet for it. And so people would be getting these horrific opportunistic infections and would die from the complications of that. And then not even to get into the social stigmatization, but people dying alone, like family being afraid, not wanting to see them. Like, it's really sad if you think about it. Then they had the development of HAART, and then you can see that it increased significantly. But there's still cultural differences that persist even today. Like, is there any good reason that we can think of that a black person should survive 30 months less than a white person? I can't really think of a good reason, right? I don't know what those reasons are, but I'm just saying that they exist. Like, there are disparities that we need to think about. Like, even though it might be uncomfortable, but it's something that we need to think about. But the good thing is that since we have these drugs, we're seeing an overall increase in survival. So getting diagnosed is likely to happen at the early stage, and not when you have AIDS, but people that do have AIDS are still able to live quality life because of the good medications that we have. Okay, another thing that I find interesting when you're dealing with a chronic life-threatening illness is that you would think, oh yeah, people are going to adhere to their medications. Nah. Like all of you who've dealt with patients, you know that that's not the truth. And even me being an educated person, sometimes I'm like, it's just laziness, like, or forgetfulness. I'm like, I'm supposed to take this medicine, I forgot. And so there are disease and treatment factors. So sometimes they have comorbidities that make it hard to take the drug, or there's adverse reactions or events. They don't like the side effects. That's probably the biggest thing, is that people don't like the side effects. If you think about interpersonal factors, your relationship with your doctor, your social network. So if you don't feel like anyone cares about you, or you don't feel like you have anyone in your life, then why would you care about taking medication? Right? Like, why should you care? Like, you're not going to care as much about your life, which is just, I think, a sad truth. And then sometimes you don't want to take the medication because you're afraid it's going to force you to disclose your HIV status somehow. I think there's still a lot of social stigma involved around HIV. And then the personal patient factors, so cultural beliefs, education level, their personality, their stress level, their daily routine. So if someone has a very tumultuous life, they're going from place to place, they don't have a steady home, they don't have a steady job, it's going to be harder for them to adhere to their medication. So again, I think it's really easy as a clinician to judge people, like to be kind of judgy, because you're up on your little pedestal of being educated, but you also don't know what people go through. And so you just have to kind of keep that kindness in mind, that it might be frustrating to you that they're not taking their medication, but there's reasons. Everyone has reasons why things fall by the wayside. Okay, this is showing untreated HIV infection, and I always have this on an exam, and I just ask you questions about it. And so if you look at the red line, the red line is the viral load. So notice that the viral load goes up very high during acute HIV infection, which is early on, like the first couple months. But then it drops significantly. What makes it drop? Antibody production, initially. So the green dotted line is when your antibodies start to go up. And surprisingly, they stay steady throughout. You don't have a decline in the antibody production, but what you do have a decline in is the T helper cells, which are the blue line. And once it gets to a certain level, that's when symptoms start to pop up. And so it's kind of like this balance between keeping the CD4 count high and the viral load as low as possible. That's how treatment would help. But if you didn't have treatment, within 5 to 10 years, your CD4 count would drop to below 200, and that's when they clinically say that you have AIDS. And my understanding is that you don't un-AIDS. Like once that CD4 count has dropped, you would technically have AIDS, but they can get it back up. They can get it back up over 200 with proper treatment. But notice that there is now at this point a crossroads, right? There's a breakdown in the immune system. So the CD4 count drops off precipitously. That's going to cause HIV to shoot back up. It's going to overwhelm the body and the immune system, and then you're more likely to succumb to opportunistic infections. The interesting thing, though, is that now the drug treatments are so good that HIV patients are dying of old people stuff, which is cool. Like they're dying of like heart attacks and cancer and stroke, fatness. You know, like I'm like, we're all going to die of fatness someday. So that's like happy, like, you know, that they're not dying from these nasty infections necessarily. They're just dying from regular old people stuff. So they're living for a long time. All right, so I have a chart there that, again, you don't have to, you could use this if you wanted to and take a picture of it for extra credit, like part of your extra credit. It doesn't matter to me how you do it. I'm just looking to see that you're reviewing. Okay, so we have this to fill out for what we just talked about. All right, so I'm going to stop there for now and pick up next time. I hope you guys have a wonderful break. You've earned it.